So here is part 3 of gendered health and aging. So this is just the standard men's health talk. We got a bunch of different things that we're going to talk about. We're going to talk about both sex and gender related issues with men. So here we go. I also like to call this talk a shop manual for the male body. Basically, it's hard to get men to come in and have health care, and so I think that if we shifted our emphasis to preventive maintenance, a lot of them would be a little bit more likely to do that. I'm always fascinated by somebody who has a job like an auto mechanic or works at a nuclear plant or whatever, and their job is usually preventive maintenance. When you ask them why they didn't come in for a physical, they say, I only come in if there's a problem. And sometimes that's a teachable moment for them so that you can, make them understand that preventive maintenance is just as important for your body as it is for their machinery. So we'll talk about both gender-related issues for men's health and also some sex-related issues. So gender-related issues would be health behaviors, the protective benefit of marriage for men as far as health, risk factors in accidents, suicide and homicide, lung cancer, which is usually related to smoking, so therefore is a behaviorally related issue. And then we'll also talk about some reproductive health issues, some male pattern balding, as well as HIV. So when we look at cancers, we can see that the majority of cancers are usually related to behavior. Lung and bronchial cancer is usually related to smoking. We look at in 2010, which were easy statistics for me to access. You can see that more men died than women of cancers. Women actually have a slightly higher risk of death from cardiovascular disease, although they have it at about 10 years later than men do. You can see that reproductive cancer is second for both, breast cancer for women, prostate cancer for men, and then colon and rectal cancers combine to be number 2 cancer overall, but for men they're technically number 3. And then you can see pancreas is often behavioral, and going down we can see that behavior is a factor in many of these cancers. That was cancer deaths. If you look at cancer incidence, you can see that breast cancer is very common in women, although they don't die from it anywhere near as often as they die of lung cancer. And you can see that prostate cancer is a very common cancer as well for men. 28% is a little higher than most estimates that I've seen as far as actual prevalence. But this is, again, not the prevalence of prostate cancer, but the percentage of cancer cases that are prostate cancer. So overall in the population, you're probably looking at a lifetime risk of prostate cancer of around 15 or 16%. But once you get cancer of some kind, 28% of those are prostate cancer. So death rates, these are interesting because if we look at what had happened over about a 20-year period, we see that heart disease has gone down, cancer has gone down, all of these have gone down, although cancers have gone down a little less than cardiovascular disease. Cancer death rates, we can see that the incidence of lung cancer as we get past that cohort that had smoked so much. Also, interestingly, we see that the death rate from prostate cancer does seem to be going down. I think it's actually very interesting that the trajectory is almost exactly the same as lung cancer. We can see that PSA screening actually decreased in the late 90s, and rates continue to go down. But I truly believe that it's other risk factors that are probably causing that decrease as opposed to anything related to screening. Colorectal cancer is also going down, as you can see, and pancreas cancer is relatively stable, leukemias are relatively stable, liver cancer slight increase, stomach cancers, which interestingly back in 1930 were number 1, have dramatically decreased. to the point where they're one of the lowest now. It is interesting because this probably was related to two things. One was preservatives, which a lot of people feel like preservatives increase the risk of cancer. And they may have certain types of cancer, but they decrease the risk of stomach cancer. The other thing is the advent of refrigeration. So better storage of food and better preparation of food seems to have decreased the risk of stomach cancer. If we compare this to women, we can see that lung cancer is actually more stable in that group, although hopefully we'll start to see a decline again. Death rates related to breast cancer. Interestingly, self-breast exam was actually popularized about here in the early 1970s. We see that the rates were roughly similar. Mammogram came in the 1980s. We see the rates are roughly similar. And then we see that about 1995, we start to see a decline in breast cancer incidence, probably related to better treatments. Although these are actual rates, so that would decrease death rates, but it wouldn't actually decrease incidence. So probably other factors in the environment, really unclear exactly what happened. Uterus, you can see, was one of the #1 cancers back in 1930. The other, interestingly, was stomach cancer, just like men. Both of those have declined. Uterine cancer, at least in part, due to screening. That is a success story for screening. On the other hand, stomach cancer, again, is probably refrigeration. It is interesting because of this success rate for uterine cancer screening, we tend to want to use that model and apply it both to other women's cancers and also to men. Hard to do that, actually. Ovarian cancer, as you can see, not only has the rate stayed stable, it's actually gone up very slightly here. And then pancreatic cancer is roughly stable in women. So when we look at men, if we look at adults age 18 to 64, we see that women are way more likely to have had an office-based experience. So 80% of women have had one or more office visits during that time. On the other hand, only about 59% of men. Probably this is related to two things. One is women come in for reproductive health issues, and then men also tend to avoid offices. Why? I don't know. Personally, I think that they often have a negative experience associated with hernia checks and testicular exams when they're younger, although I don't really have any evidence to support that conjecture. If we look, about 2.8% of men had not been to an office in a year. On the other hand, about 12% of women had not been in. So when men are married, it does seem to be protective. The relative risk rate of death in married men is only about 88% compared to unmarried men. Why is that? Well, it probably is related to health behaviors and seeking out health care. If you look at never married men, you can note that they're actually even higher. They're about double the risk rather than just 12% higher. And again, probably those folks are much greater risk takers, not as good as far as dietary intakes. Widowed men have a relative risk of about 11% higher, odds ratios of about 11% higher. Again, they probably do not eat as well. They probably may also be depressed, and there's also a question of whether there even is some risk of increased risk of suicide. So non-married men do have much higher mortality. So we can see that the risk is substantially greater in younger people. Obviously, they're probably greater risk takers, and it's I think particularly interested when you look at widowed folks, the increased risk of death goes up substantially. These are old statistics, but these were done by Gove down in Tennessee, and subsequent numbers have been similar. So you can see later ages, less risk, but still risk. Other non-reproductive health issues, a bunch that we'll talk about here. So in general, men die younger, and so our death rates per 100,000 are substantially higher than women. The differential in life expectancy in 1900 was only 2 years. By 2000, that's 5.4 years. And so it does seem like women have actually had greater benefit from both public health and other medical advances. So the top 3 killers, again, similar for men and women. Heart disease is number 1. Cancers are number 2, and cancers are a bit more prevalent in men. And then accidents are number 3 for men, and CVAs for women. So obviously health behaviors are more of an issue for men. So again, as we go down through, we can see that number 4 is accidents for men, and then number 4 is Alzheimer's disease for women. Number 5 is suicide for men, and number 6 is homicide for men. So again, obviously behavioral things are substantially more important for men than for women, it appears. So HIV is definitely a disease that is still predominantly a male disease. About 73% of new cases are still men, predominantly men that have sex with men, IV drug users. There is more heterosexual transmission, and of course the 27% that are new cases that are female does represent a substantial increase from a number of years ago. But again, 3 out of 4 cases of HIV, new cases, are men. Heart attack, again, men get a heart attack about 10 years earlier than women on average. Men have a 19% higher incidence of stroke and are more likely to die from stroke if they have it. And then there's at least 7 million men that are living after having had a heart attack and having angina type issues. Cardiovascular mortality trends. I've actually got 2 slides here just because I think it's interesting that in 1996, back when I first created this talk, you could see that the tendency for males was down, but actually flattening out. And for women, it actually was maybe increasing slightly. Now we look at what's happened since 1995. And we see that for men, we did actually see a substantial decrease, and for women, we're also seeing a substantial decrease. What this is related to, it's really hard to say, whether it's more statins, whether it's lifestyle, whether it's interventions, but either way, cardiovascular disease trends are downward. Obesity, even though we often think of obesity as being more of a woman's issue, just because women are way more aware of it and way more interested in losing weight, it seems, at least 40% of men are overweight, 10% of teen boys are overweight. Socioeconomic status is clearly a risk factor. So in people that have low socioeconomic status, 1 out of 3 of them is obese. In people that have higher socioeconomic status, only 1 out of 20 is obese. So whether that is access to higher carb foods being cheaper, whether that's just lifestyle or behavior, whether that's access of the people with higher socioeconomic status to gyms and things like that, it's not clear, but it is clearly an issue that is not blind to socioeconomic status. So again, trends in overweight. I think this is not any surprise to anybody, but if you look at the number of people, the states that have an incidence of more than 55% of obesity, as compared to less than 50%. You can see that from the early 90s, the numbers have gone up, that essentially the entire country has a number of folks that are overweight. Sleep apnea clearly is related to obesity. We see it more in males than we do in females, although we definitely should have more awareness of it for females and think to test for it more. Probably at least 1 out of 20 adult males does have sleep apnea, and especially if someone has fatigue or other similar issues, you definitely want to keep this on your differential. Unfortunately, a lot of men either don't come in for care, are very stoic and don't want to complain about being tired, but generally if you ask them, they will admit it, and we probably should do more sleep studies than we do. Hypertension is a risk factor. Hypertension does seem to get better when you treat sleep apnea. A lot of the other things that have been attributed to sleep apnea treatment, such as weight loss, have very mixed evidence for them. Does not seem to be a major benefit. So if we look at the incidence of being overweight versus being obese, we can see that non-Hispanic black women have a very high incidence of obesity, and Mexican American women also have a high evidence of obesity. But if we look at overweight, we can see that the men actually are substantially greater as far as the percent that are overweight than are women. So this trend seems to be moving towards obesity as well. So melanoma is definitely a gender-related issue. Incidence seems to be, death rates are higher in white men. Not sure why the death rates are higher, whether it's later diagnosis, increased prevalence, but it definitely is something that we need to be aware of. It is only 3.3 out of 100,000, but it is increasing. Men are more likely to have lesions on their back. I always make a point to look at men's back. I don't necessarily do a full body evaluation looking for issues, because melanoma often is sun-related, although not always. Testicular cancer, the death rate is quite low. Only about 350 to 400 men died of testicular cancer last year. It notes the 200 to 2005 death rates. If you look it up, it's roughly stable. Interestingly, that's roughly the same number of men that die each year of breast cancer. So it is interesting that some people really want men to do testicular self-exam, but not breast self-exam, even though their risk of death is roughly similar for both. If someone has had an undescended testicle, it does increase the risk of testicular cancer, making it about 10 times, so that it is definitely something that you want those young men to be aware of. I don't necessarily recommend testicular self-exam, but I do, especially in that group, tell them to be very aware of what their testicles feel like, and if they feel any abnormalities, to let me know. Doubling time for testicular cancer is fairly quick, 10 to 30 days, and a fair number of males do have metastasis at the time of diagnosis, probably as many as half. Strangely, or very positively, men tend to respond very nicely to cisplatin, and the survival rates are actually excellent, even if there's already metastasis. Lance Armstrong, the bicycle guy, actually had metastasis to his lungs and his brain at the time of diagnosis, and he's responded, and he's been cancer-free for a number of years. So testicular self-exam, the Clinical Preventive Services Guidelines basically say that it's unlikely that screening would improve the already favorable outcome in this uncommon disease, and so who knows whether it's useful or not. As I say, I personally think that if only 400 kids or young men die of testicular cancer each year, and over 2,000 die of suicide each year, that your time is better spent talking about mental health and other issues rather than teaching them testicular self-exam. But, everybody has to make their own decisions and estimation of risk. Penile cancer obviously is a rare cancer now. Many of us have never seen a case. I haven't seen a case in probably 20 years. There originally was some question whether or not there was some incidence of being uncircumcised and having penile cancer. Later evidence says that there's really no relationship to that. There's a slightly higher rate of UTIs in uncircumcised males, although that does not seem to increase mortality or even seriously morbidity. There were some early reports that babies that were not circumcised actually had more bacteremia, but I think that actually turns out to be that babies with bacteremia don't get circumcised. So circumcision in and of itself probably does not have any health risks, probably also does not have any health benefits. It really is probably most likely a condition in which it is a social issue. There is some question whether or not there was some increased benefit as far as being uncircumcised, as far as not getting HPV. To my knowledge, there's not really any strong evidence for that at this point, but I'd be open to being contradicted on that. Again, the circumcision rate is roughly stable now. The rates actually dropped a number of years ago, and so there still is a substantial number of boys that are uncircumcised. They do have a slightly increased risk of UTIs, but again, whether this is an important clinical issue is unclear. There are men that have been circumcised that feel like they have been emotionally damaged by it. There is actually, if you go on the internet, a movement towards foreskin restoration, and there are ways that you can stretch the already existing skin, but obviously this is not a particularly common thing. Obviously, female circumcision is something very different because they usually remove the clitoris, and they do it for different reasons. On the other hand, men that are against circumcision feel like this is an unnecessary surgery that is just being done for religious or convenience reasons, and if you're not that religion, then why would you do it? Interesting questions. No simple answer to those questions. I think it's really important as a clinician to, again, do shared decision making with families and let them decide. I don't think there is compelling evidence in either direction. And so, as I say, when someone asks me, I refuse to sort of offer an opinion and suggest that they explore the situation themselves and make a decision based on their own values. Common phenomenon that a lot of folks are not aware of are varicoceles. So varicoceles are when you feel the testicle and you feel some dilated veins in the area. Basically, they're varicose veins, hence that's why they're called varicoceles. And basically, it feels kind of like a bag of worms. As many as 1 out of 6 men has a varicocele, very common. If you feel it traditionally, it's on the left side. The right side seems to be an indication of more issues. So if you have a acute onset right-sided varicocele, the risk of an abdominal or other cancer is a bit higher. On the other hand, I have probably 2 young men a year that ask me about it during physicals or come in specifically to have it checked. Usually when they become sexually active and their partners are feeling the testicular area, they say that there's an abnormality, and there's definitely just some education that needs to happen there. Varicoceles do seem to be associated with an increased risk of infertility, although if 1 out of 6 men have them, then clearly it's not a major factor as far as infertility. Hydroceles, which are just a fluid-filled area, will transilluminate. So if you put the otoscope on them in a dark room, the whole area is going to glow. The fluid is basically going to take on the light. pretty easy to tell that difference between a spermatocele and a tumor. With a hydrocele, if you have a child who has a non-communicating in the first year, you can usually wait for it to resolve. Basically, the difference between a communicating and a non-communicating hydrocele is whether it gets bigger and smaller over the course of the day. So basically, a communicating is it's still communicating with the intra-abdominal fluid. The non-communicating is not. Personally, if I have either one, I give them 9 months to a year to resolve. If they don't resolve, then you can refer them to urology, and then they can possibly remove them. You also see a hydroceles again as men get elderly, and it is a similar situation in which there are generally very benign findings, but they can be removed if they are enlarging or if they're problematic. If they're enlarging, it does raise the possibility of a intrascrotal cancer, although in general cancers in that area are reserved for young people. There is a slight bump again in testicular cancer at around age 60, although it is nowhere near the risk of the late teens, early 20s that usually is the issue. So prostatism, we talked about prostate cancer in the last talk, so we'll talk mostly about prostatitis and prostatism in this one. Prostatitis is infection, and prostatism is enlargement related to benign prostatic hyperplasia. So most prostatitis in young people is going to be a sexually transmitted infection. Chlamydia is definitely one of the possibilities. If you're going to get a urine to test for chlamydia, make sure it is a dirty urine, meaning that they put the first amount of urine in it, they don't clean themselves off first, and they have to have not urinated for at least an hour. Clean urine, of course, is midstream, and they've cleaned themselves off first. So with chlamydia, obviously you would just treat for chlamydia. You can also have a prostatitis that's secondary to a UTI. I've seen them related to patients that have been in the hospital and have had Foley catheters. They will have kind of UTI symptoms, although their urine will look clean. So they've got some dysuria, they've got some pelvic pressure, they just don't feel good. If you do a rectal exam, oftentimes the prostate gland will feel boggy, so kind of more the sensation of a jelly donut than the sensation of a medium to medium well steak. So you might have a little bit of give in the prostate. You should have a little bit of a give. It should not be rock hard, but it should be about the amount that you get with a medium steak, as opposed to just a mushy, marshmallow type. If you've got a marshmallow type, especially if it feels warm and especially if it's tender on palpation, it does support the diagnosis of prostatitis. If you look up in the Sanford Guide, it talks about treating it for 10 days. My opinion is it needs to be treated for at least 30 days or more, and even then you only get about a 55 to 97% success rate. Symptoms may come back and you may need to repeat your treatment at that point. So prostatism is basically the syndrome in which someone has urinating more often, a little bit of decreased force. I had a urologist friend that used to ask people, can you still write your name in the snow? They get up at night to pee more than once. Once is considered normal, twice is considered nocturia. They may have difficulty starting their stream. It is almost always age-related. Usually men in their late 50s to 60s will start having this complaint. Treatments can include alpha blockers and finasteride. Alpha blockers just relax the sphincter. Finasteride may take 6 weeks or more to work, but it actually works by blocking the male hormones that are involved in the enlargement of the prostate, and it'll cause the prostate gland to shrink. Obviously, you need to do blood testing and rectal exam to rule out evidence of a prostate cancer before you would diagnose somebody as having a benign prostatic hyperplasia. Normally, the BPH often is referred to as hypertrophy. Hypertrophy is actually something that is subtly different. It's actually the same number of cells, but with the cells enlarging. Hyperplasia is an increased number of cells, which is actually what happens. But nobody's going to get too upset if you call it benign prostatic hypertrophy, but hyperplasia is technically the more correct term. If somebody doesn't respond to medication treatments, you can refer them to urology, and they can actually usually do laser or other more aggressive ways to open up the urethra and make the surgical capsule, the inner part of the prostate, more likely to allow drainage. So prostate cancer, as noted, both the digital rectal exam and the PSA are both D recommendations. There at one time was a question whether or not vasectomy increased your risk of prostate cancer. Back in 1993, there was a couple of studies that questioned that. No other study since then has found evidence of that. So again, cancer incidence rates, we've already talked about prostate cancer, and this is, again, incidence rates, not death rates. And we did see the bump associated with a more aggressive case finding, did not really seem to result in decreased death rates, and we've already talked about some of these things previously. Again, Cancer Society, if your PSA is less than 2.5, you can probably go to every 2 years. If your PSA is above 2.5, they suggest testing it every year. But these recommendations do seem to change on a regular basis. Another thing that some people were looking at was the PSA velocity. And basically they said that on average, people's PSA will increase about 0.4 over 3 years. If it increases more than that, it might increase the possibility that it's a cancer. There's not really any evidence that is strongly suggesting this. On the other hand, I will tell you that if someone's PSA has gone from 2.0 to 3.1, that a lot of clinicians will actually repeat it, asking them not to have sex for at least 72 hours before. And then if it's still elevated, consider earlier recheck and or maybe sending them to urology for discussion. Again, PSA density is something that has been discussed as possibly a way to stratify risk. The higher PSA density seems to increase a greater likelihood for cancer, and basically that involves using a ultrasound to really get an idea of how big the prostate gland is, although you will find urologists estimating the size of the gland based on the number of finger widths that they can feel rectally. They'll actually say it's a 30 gram or a 45 gram or whatever prostate gland, which is fairly well correlated to ultrasound based on exam. Again, PSA density is something that you need to be aware of. On the other hand, as of right now, it doesn't really seem to have any benefits. Percent free PSA is another thing that some people will get. They'll get a PSA which will reflex to free PSA. The problem is that the range of normals are extremely wide, and the percentage of free PSA is lower in men who have prostate cancer. But if your free PSA is 10% or less, you might not need to have additional testing. I'm sorry, you do need to have additional testing. Again, my feeling about this is that if you have that person who has substantial acceleration of their rate, I leave it up to urology to decide whether or not this is a useful test and decide whether or not to do this. So, as noted, other issues in PSA, we think that the ejaculation phenomenon may occur and last for at least a few days. Generally, I tell them 3 days before. I had a discussion with a urologic PA a few weeks ago, and he says that he's seen the PSA go up as much as 2 points, both from a rectal exam and also from ejaculation. So just something to keep in mind if you have that elevated PSA. Some herbal mixtures are shown to have some benefit for prostate health. but they also do seem to mask that PSA level. So if someone's on saw palmetto or other similar, make sure that you take that into consideration if you are still doing PSAs on them. Obese men tend to have lower PSAs. The significance of this is not exactly clear. But again, if you are a believer in PSAs, you might want to look at the velocity and the trend in those folks even a little bit more carefully. Prostate cancer treatment, radiation and surgery are the mainstays. Lots of times patients will be given a choice between the two. The PIVOT trial did suggest so far that as far as what we've seen from the results, that watchful waiting is a reasonable alternative. But again, that is surveillance. That is not just ignoring them. So other behavioral issues, again, keep in mind that men commit suicide at a rate 4 times that of women. White men have the highest rates. Male deaths from homicide are also 3.3 times that of women. We talk about women being murdered by men. In fact, men murder men a lot more than they murder women, but it is definitely a risk factor for women that women don't usually murder men. Substance abuse rates are about 3 times as high in men. It is very interesting because mental health issues seem to be higher in women, but if you actually take substance abuse for men, mental health for women, and you actually compare them, rates turn out to be roughly similar. So it's possible that men are having mental health issues that they are just self-medicating with substance abuse, but it's unclear exactly what's going on there. Erectile dysfunction, about 30% of the men 40 to 70 years old do have it. Many have a concomitant disease. They're either smokers, they have hypertension, they have diabetes. In general, though, we're just going to go ahead and treat those people similarly. Viagra is a common medicine. There's also Cialis and Levitra. A new phenomenon that has occurred is that sildenafil, which is Viagra, is now available in generic. Viagra per se is not available in a generic because Viagra is 25, 50, or 100 milligrams. Sildenafil, before it was Viagra, was a medicine called Revatio that was used for pulmonary hypertension. That was 20 milligrams 3 times a day. That medicine, about a year ago, came available as a generic. Now, it doesn't know that it's not Viagra, so it works just like Viagra. So that depending on the pharmacy, 20 milligram tablets can be very inexpensive. So the pharmacy that I usually work with that's affiliated with York Hospital will provide 30 20 milligram tablets for about $40. Patients can take 1, 2, 3, 4, or even 5 if they need them. It is strange because if you go to GoodRx, you'll see that Rite Aid actually still lists Revatio generic as if it's Revatio brand, and says that the cost is about $460, whatever it is. It's outrageous. So you just have to warn patients that they do need to look up on GoodRx or in some other way investigate this before getting that sildenafil prescription filled. Anecdotal reports of combining one of these medications. They're called PDE5 medications because that's the enzyme that they block. Seems to be some evidence that if you take them with nitroglycerin, you'll get a dramatic drop in your blood pressure. There's definitely anecdotal reports, although there's not that many of them. There are alternatively for people that are either on nitroglycerin and can't come off, or that they don't respond to the PDE5 medicines. There are actually injections that can be given. I have a patient that uses these and really feels like they're very effective. Again, like any of these medicines, they can cause the 4-hour erection, the priapism. Treatment for priapism involves sticking some needles in the penis and draining that cavernosum. So it's pretty aggressive. But in 30 years of being a nurse practitioner, I've seen priapism twice, and neither times was it as associated with PDE5 medicines. So the urethral suppository exists, but it's actually hard to find. So just to mention it. Now, if someone's failed all other treatments, or if they have all other treatments contraindicated, there are vacuum devices in which there's a vacuum that's placed over the penis becomes erect, and then there's a ring that's placed around the base of the penis to hold it erect until the sexual act is completed. Sometimes in cancer patients, this is the only thing that you can do. There's also penile implants that can be done. We did these frequently before the PDE5 drugs for diabetics and some other folks that were having erectile issues. Most of those, the penis is sort of semi-erect all the time, although there are some pump-up ones. The challenge is those valves have failed often, so patients would have to be aware of the possibility that they could fail. So again, back to erectile dysfunction, the actual brand name of Viagra is still very expensive. I do have patients that get it from Canada. If that's the case, they either call and talk to a prescriber there who prescribes it over the phone, or alternatively, you can give them a prescription that's just the generic paper prescription and that they send to Canada. I never actually send the medicine myself to Canada just because I think there's some gray areas legally, but if you give them a paper prescription and they send it, that's not really anything that you have control over. 16% of people on Viagra will get headaches, so just it is a side effect that they should be aware of. Male pattern baldness. There's a number of different treatment options. They can use the hair club. There's sometimes a weave, there's sometimes implants that can be done. They can get toupees. Minoxidil is about $30 a month. It's mildly effective, but does require aggressive treatment. You can use it with Retin-A. You can also combine it with Propecia or Proscar that I'll talk about in just a second. So finasteride is a medicine that we use for enlarged prostates. That's called Proscar at 5 milligrams. If you're using it for male pattern baldness, it's a 1 milligram tablet taken daily. It is not prescribed in the 5 milligram tablet just because it doesn't seem to be any more effective than the 1 milligram, and you get a lot more side effects. About 10% of people will have increased hair after about a year. When you get benefits, you get benefits. When you don't, you really just don't get anything. Other things to remember is make sure that when you're prescribing SSRIs for men, that you warn them that they may have delayed ejaculation. In a young man, this actually can be a desirable side effect, but in older men, it can actually be pretty distressing to them and interfere with their sex life. A number of different medications can cause gynecomastia. Marijuana, digitalis, tagamet, so definitely keep that in mind. But also when you have gynecomastia, make sure you do think of other things such as hyperthyroidism. So to summarize, in general, men underutilize health services. Lots of the causes of morbidity and mortality are related to their behaviors, but we did definitely review some specific reproductive health issues as well that you should be aware of.